Good afternoon, everyone. Thanks so much for making the time during Common Hour when I know it's quite a busy Common Hour across campus. We always end up, unfortunately, scheduling too many simultaneous events. But I want to thank you and congratulate you for attending the right event during the Common Hour. So this is the Distinguished Faculty Lecture for the spring semester. A little bit about the program, and then I'll introduce our two distinguished colleagues. So the program started in 1981, inaugurated at the university to recognize distinguished faculty and their contributions to the educational mission of the institution, the scholarly research mission of the institution. And since the fall of 2000, we've done 2 lectures per year, one each in the fall and spring semesters. So those of you counting, this makes this the 60th Distinguished Faculty Lecture. I should just point out that moving forward, those of you that are thinking about applying or nominating folks for the following semesters, we're tweaking the program just a little bit. You know, in recent years, in the fall, we've recognized distinguished faculty focused on scholarly research, and in the spring on innovations in education. Those are 2 topics that continue to be relevant, but we're not going to be quite so programmed in fall and spring. So we want the best ideas to come forward each and every semester. So we're really excited today to have 2 of our colleagues from the School of Nursing and Physician Assistant Studies here with us. And so let me tell you a little bit about both Gina and Christine, and then I'll let them get on and tell you about the great work that they're doing. So first I'll start with Gina Pontrelli, who is a certified physician assistant, completed her doctorate in health sciences in 2019. She did graduate level training in a very rigorous interdisciplinary education environment that promoted excellence in teaching, scholarship, leadership, and of course service. Her dissertation title, Do SPEs Improve Physician Assistant Student History Taking and Physical Examination Learning Outcomes as Demonstrated by the PANCE Task Scores? As a chemist, I don't know what the PANCE task scores are, but I'm sure I could find out from you. So Gina's both a course coordinator in the physician assistant graduate and undergraduate level course programs, and she continues to be involved in research, publication, and service for the benefit of not only Hofstra, but also our community and on the national level in professional societies. And the co-presenter is Professor Christine Zammit, who is an assistant professor in the Department of Physician Assistant Studies as well. She has an extensive experience in PA education, serving here as Hofstra as a full-time faculty member for the past decade, and was an adjunct at 2 other New York PA programs. So we're thrilled we were able to recruit her here since joining Hofstra about a decade ago, as I said. In her current role, Christine is also an academic coordinator and is responsible for developing and delivering the curriculum to preclinical PA students. In addition to her work in academia, Professor Zammit's a clinically practicing PA in pediatric critical care for the past number of years. How's that? Okay. So it's a great pleasure. Please join me in welcoming both of them.
Hello. Thank you all for being here. Thank you to the Provost's office for this really very exciting opportunity for us to tell you a little bit about what we've been doing at the PA program to try to engage our students and enhance their learning so that we can graduate really proud Hofstra PAs.
Yeah, so as mentioned, back in 2019, this was a top and still is a topic that's near and dear to my heart, simulation and how it affects medical education. So today we're going to be discussing some of our research on gamification combined with simulation and how it's used in physician assistant education in our program. So, right, active learning, right, and critical thinking skills are necessary as clinicians, right? As clinicians, we need to think quickly. We need to act on our, feet, make quick decisions, and, simulation can as used properly within integrating in the curriculum, it can give students the confidence that they need. And combining it with gaming, it sparks that motivation, that internal motivation to do better and to learn. So these scenarios, they mimic real life cases and things that we can't always replicate. Something like, for example, the obstetrics and gynecology patient, right? Our pregnant patient. We can't always find actors or, simulation cases to, give us these situations. So, having the simulation and gaming gives us these opportunities and allows students to refine their skills, allows them to repeat and go through these situations various times. So, if we separate the two, simulation meaning, an activity that creates a real life situation, these high fidelity cases, whether it's being an actor, a standardized patient, these virtual cases that are a little different than gaming. So gaming is an activity that's meant to motivate our students. So I know we're all into the Peloton, right? And getting fit and the leaderboards that go on. So that's part of gaming, sparking, the individual to do better, right? So whether that being, we know what our students like, grades. So either adding something as points in terms of their project. So things like that motivate them to want to do well. What's nice about gamification is that we could tailor and we could customize the environment to mimic a feeling, an internal feeling that the students may get in a specific setting, for example, like the emergency room. But what's great about it is we're doing it in a controlled environment, so they feel safe. It's safe for them, they feel comfortable learning. Although it may feel stressful, it's not the actual field, right? So when you look at this picture and you hear beeps and buzzing and a lot of noise in the background, how does this make you feel just by looking at this? And I think that showing students things like this and then giving them a scenario that goes along with it, having a little timer in the right-hand corner, right, showing vital signs that we can alter as faculty members. They sweat a little bit. They feel stressed. So that's an example how we could create the environment as educators. Okay, so in my experience and in my research, these should begin early on in our didactic training. And at the PA program, this is something that we do. We have our students start early on with history taking, where they go into a simulated environment, they practice with an actor, right, that has a script that faculty create, and they feel comfortable little by little as we move through the program, refining these skills, right? So we do this longitudinally, horizontally, right? So it kind of builds on what we have. It augments. They don't replace. And hopefully, it's promoting those critical thinking skills where they feel safe and comfortable. So where do we begin? Thinking outside the PA program, I wanted to share, our experience with other departments. Maybe plugging these situations into existing curricula. So for engineering, for example, I saw a lot of examples on what they're using in terms of gaming and having tools that you could build out projects. So there's a lot of options out there. And it's really up to the faculty member and educators, like, what are your goals? What are your benchmarks? And each activity, I think, can really be tailored to that. What's nice, in addition to the practice, as I mentioned, and repetition that builds confidence, we have these objective measurements. So as students go on throughout our program, they're not just being graded by us faculty who sometimes, although we don't want these things to happen, we have these preconceived opinions about some of the students. So they'll be graded by either a standardized platform, a standardized patient. So there's more of this objective measurement, right? So it removes the faculty bias from the equation.
So simulation has for many years now been shown to be very beneficial in medical education. It has a positive effect on clinical judgment. It forces students to think on their feet and to think, if I do this, what are the possible repercussions of my actions? So rather than that quick answer on a multiple choice exam, they have to think, if I give this medication, or if I do this intervention, what is the outcome going to be? So they have to think about some of the implications rather than just kind of that yes, no, black and white. It's also not always easy to, as faculty, to assess skills on a paper and pencil exam, to assess those critical thinking skills. We're not always able to do that on multiple choice exams. So as this is a great learning activity for the students, but it also is for faculty a good way to assess their knowledge, also assess any knowledge gaps. Is it an individual student knowledge gap, or is this an overall gap? Do we need to kind of look back at how this was taught, how we're presenting this, what does our curriculum look like? Do we need to make any adjustments in the curriculum? And again, it's medical education, health professions education talks a lot about milestones. So when we're thinking about developing these cases and developing the rubrics, this is a great way to show student progression, right? We hope that when a student starts with us and when they end with us, they look very different. And if they were to see the same patient on the first day of class and the same patient on the last day of class, that they would interact with them differently, that they would treat them differently, and that their entire interaction would be different and their knowledge would be different. So it's very helpful to utilize these types of situations to demonstrate student progression throughout the entire curriculum. The other nice thing about simulation and also gaming is that it's very adaptable to very different learning strategies, right? Many students learn very differently, and this helps you to be able to engage with students who learn differently. If we take a look at it in terms of several different learning theories, the constructivist theory, students learn best. All of our students come in with knowledge from the outside, knowledge that they got from watching Scrubs or ER or what on TV, or what they've seen online, and then now they can see it in a real patient, and they can actually they can take what they learned from outside to what actually is and make and transform into new knowledge. And so simulation is very helpful for this. It's dynamic and continuous. It doesn't end. One of our favorite questions our students ask, well, we learned that last semester, so do we need to know it this semester? Yes, you need to know it for life. Life is cumulative. That's one of the things that we tend to tell our students very often. And again, this is a continuous and dynamic way of learning. And as students improve in their skills, they become more empowered as they start to lead the scenario. And this is our goal, especially as they will eventually be going out to clinical rotations and then eventually be taking care of patients on their own. The gamification piece of this specifically is applicable to the behaviorist theory of learning because students like to be rewarded. So by giving points and by having these leaderboards, it's really helpful for them. In addition, that immediate feedback. So with the gaming piece of it, you find out where you are on the leaderboard, you get your score pretty quickly. And with simulation, there's feedback right after the encounter. We know how this generation appreciates very immediate feedback and immediate gratification. So doing these immediate things right after the simulation or the gaming experience can be helpful, can help the students, and again, also plays into how they learn, plays into that feedback, and doing this in the classroom. And then again, we can also work into this self-reflection piece. So students can watch their video with the simulation. They can go back and replay things that they did and see what they did well, what they didn't do well. And that self-reflection piece is also a big part of student growth and learning.
Okay, so Christine and I, we do not receive any sort of compensation for mentioning or, right, any of these platforms, but things that we've tried in the past, you know, of course, we have our Center of Learning and Simulation that's shared with the School of Nursing, School of Medicine, where we could share ideas. Something as full code, which we'll show you, will take you through a full code case, which is a customizable simulated experience where we could change the environment, the age of the patient, and what their presentation is. Things that the university has available to us, like Poll Everywhere, where we can insert questions on our PowerPoints, and platforms like Kahoot. So, you know, in the past, students have called these things to be busy work. So it's really important for us as educators to implement them or implement these tools in the right way and to use them strategically. And how are we using them? So again, it's to, you know, our goals within our program to improve quality care, reducing medical errors, promoting behavioral change, having, you know, that self-reflection piece where the students could think about the case that they went through, they could go back, revisit it, replay it. They have the instant debriefing with faculty where they get that feedback as well. So hopefully all these things will, you know, change behaviors, change practice, in hopes to make them better clinicians. And again, working out the kinks before they're actually out there on the field where they could harm someone. So here's a little, you know, this is a photograph of our CLI or our simulated experience and how we use it in the program. The first picture here, you can see we have a hallway. Usually this is where our faculty member has a headset that we could place over our ears and watch this encounter without the student being able to see us. So there's what looks like a piece of glass, but the student can't see out, right? So we're able to see what's going on. There are recordings as well within the room. And here's the students picking up, you know, what's the triage sheet or the door chart where we can display it on the computer. They could go through, you know, what's your chief complaint? What's going on, some of the pertinent elements of the case before they actually go in and enter the room. And here's an example of that.
Learners, once you have read your door chart, you may begin your encounter.
Come in.
Hi, are you Ryan Phillips?
I am.
And may I have your date of birth?
Sure, it's 4/1/1967.
Great, I'm in the right room. My name's Jamie Woj, I'm a first year medical student, and I'm just going to be asking you some questions about what brought you in. Is that all right?
Yeah, of course.
Sure. Just to start, I'm going to wash my hands real quick, and then I'll be right with you.
Sounds good, thanks.
So without having you watch this entire video, that's just a little snippet of what we put our students through. It's this protective environment, you know, where it builds throughout the curriculum. It starts with learning history, right? We get a robust history, we move on to combine the history, the physical exam. Then as they progress, the history, the physical exam, and assessment, where they come up with a diagnosis and then a plan. So that's how we see them through, you know, as competent clinicians.
So as we mentioned, simulation is used to enhance critical thinking, and there are options whether you decide to use standardized patients or utilizing things like virtual simulation. And virtual simulation is certainly helpful in terms of if those patients that are difficult to replicate and difficult to have live, you can use virtual simulation for that. One of the ways that we challenge our students to take all of these situations seriously. That's sometimes kind of getting the student buy-in is really important as you're adding any of this curriculum or any of these things to your curriculum, making sure that you have student buy-in, and then understanding really like what are your objectives for the case. Are you looking for more communication? So then you want to be using live standardized patients to see how the students are communicating. Are they demonstrating empathy? What are your goals and objectives for the case, and that will help guide the faculty to determine if they would like to use live simulation versus a virtual type of simulation when you think about what outcomes you're looking to get from that case. When we go, like what Gina just showed, that's simulation at the Center for Learning and Innovation. We utilize standardized patients, and our rubric completely depends upon what we're looking to get out of that situation. Our beginning rubrics look more for communication. They're not assessing critical thinking skills as much because the students haven't really attained that knowledge yet. And so as they go through the program, we tend to look more in terms of their critical thinking skills and look a bit more, and the rubrics get a bit more complicated, and we expect them to perform better as they go through the program. But that's really up to faculty. And this is where you have a lot of freedom in terms of what you want to get out of the case. For sometimes it might be a very simple, a simple thing in terms of communication. For something else, we have a breaking bad news case where we have our students go in and give bad news to a standardized patient. And it's a difficult case emotionally for the students, but afterwards they say like, wow, I'm happy that I was able to do that in this safe environment and figure out what I did well, what I didn't do well, did I look up? Did I look down? Was I smiling awkwardly? Like all of those things come out in these particular sessions. So faculty can be really specific about skills that they want to use. This is also helpful for remediation. You have that student who is not really, who maybe their interpersonal skills need a little bit of work. So you can make some specific rubrics for that, specific cases, and work with the standardized patients. This is an example of just a performance assessment that the standardized patient fills out. So standardized patients are trained to give specific feedback. They're looking at different things than faculty is looking at. Again, which kind of gives you a little bit more 360 evaluation of the student, and also takes a little bit, as Gina mentioned before, of that faculty bias out of when we're evaluating our students. We're with these students in our program, we're with them for a full year. We hear everything that goes on everywhere on campus with them. So as much as we try to be objective, having additional observers and having other people is helpful for giving feedback to the students. And the standardized patients specifically really help with the soft skills. This is not evaluated as well, maybe eventually with AI in terms of on virtual cases. But for now, I think the human piece of this is really important for evaluating those soft skills in our students. And then certainly there are technical pieces of this as well. Specifically for our program, we're looking to see if our students know how to do certain portions of the physical exam. Do they know how to perform the physical exam? Does it flow well? Do they make the patient move around too much? Do they make the patient uncomfortable? Are they not paying attention to the modesty of the patient? All of these things can be incorporated into your rubric and help with the teaching for the students.
Okay, so the virtual case gamification that we used in our PA program, what was really nice is we have a large class of about 70-something per cohort. So we were able to combine the gaming experience on Zoom and put our students in small breakout rooms. So they got a chance to work together as a team. We had each student decide on a different medical profession that they would represent, whether it being, nursing, X-ray technologist, pharmacist, and again, working in this team environment to get through a case that we created, right, in this gaming environment. So the pressure's on, right? They're working as a team. They want to get points on the assignment. So it's a really nice way, hopefully, to spark that motivation. So
this is this is for any student when they're sitting. This is specifically for full code, what this would look like. So you start, here's the case. This is a video of me doing it, so I clicked on a few things so you would see how the case progresses.
Right, and giving you the examples of the evidence-based medicine that's embedded throughout as we move along.
giving instructions, telling about all the different tabs that are available. You can ask history questions. You can, what you want to do for your exam, what you want to do for stabilization, any interventions that you want. This is kind of just the going through the tabs and showing you all of that.
So these situations, we could customize them depending on what our goals are, what the class is, everything from what the patient looks like to what's going on in the monitor, what's happening on the physical exam, and the level of difficulty.
Right, and with the level of difficulty, you can say specifically like how much help you can ask from the attending physician. You have a question? Yeah.
I'm sorry.
Yeah.
Could you alter this to have, like, for instance, group versus epiglottitis?
Well, so this particular case is supposed to be an epiglottitis case. They have different ones, but very good. So they have this particular, and again, there's so many different ways to do this and so many different platforms out there. This particular platform that we've used, and we've used a lot of them, and we haven't had as much success, which is why we're talking about this one, because we thought it's been very good for our students. This particular one has about 160 different cases. And now, so like for here, like croup, when you on your differentials, that would be expected that a student would choose croup as one of their differentials. And so you, like on here, you would, as part of the grading of this rubric, would be something having like croup as like a differential for this particular patient.
The other thing we can do is reach out to the rep, and we've done this before, where we want something different, and they have customized the cases for our needs.
And then I'm trying to show ahead, like eventually you press like place on a monitor. You can see that the monitor will go on in the background. You can place the patient on oxygen, and you'll see that will change the oxygen saturation on the monitor. I'm trying to just move it ahead a little bit.
And we'll talk about this as we move through the slides, but some of these decisions, like the students can't just check yes or click off on all these boxes. If it's not the correct decision, if it's harmful to the patient, they will actually lose points. So it's not as easy, right, as this actual clip.
So there's the monitor goes up now. You give oxygen, the patient's oxygen is 87%, you give some oxygen, the saturation goes up. You can ask the nurse for something, you can ask the physician for something. Get the idea. Okay.
Okay, so this is a sample of what the students may see as what we call like the triage form, or how the case is presenting. And you could see, like, this is a gaming example, but a pediatric patient. And it goes over the age of your patient, right? Some of their vital signs like a height, their weight, significant past medical history, and depending on what the environment, for example, like the emergency room, like typically what the ER triage form would look like.
And then when you're thinking about gamification and your rubrics and debriefing, you want to think about the language that you're using in your debriefing and in your rubric. I think one of the things that we try really hard to get our students to understand is that there's not always right and wrong answers. And so sometimes things are helpful, harmful, not necessary, or necessary. And that's a good way to frame things when you're thinking about patient care. So, we try to use that language and get them out of the kind of like, this is 100% always right and always wrong, because in medicine there's not something that's always going to be 100%. We would love it if it was, but that's just not the way it works. So we try to have students understand that and really think about the implications of their actions, and then you can kind of see this is helpful for your debriefing talking about the harmful actions and why they're harmful. Like in this particular patient, why would you not use this medication? In this particular patient, why would you not place an IV? Why would you not want to agitate this particular patient? Why do you need to have them in a safe environment? Why do you need to worry about their airway? And it really helps with the debriefing and gives a platform for discussion, because if the student made a mistake, that's fine. They made a mistake. They made it here, they made it in a safe environment, and now they know if they're treating a patient in real life not to make that same mistake again. So it's really highlighting the safe environment and having them be the leader, do what they need to do in the scenario, and then having that debriefing afterwards. The debriefing, I think for us in terms of using simulation and really more using virtual simulation in our program has been the game changer in terms of how students look at these cases, because we've used a lot of different cases. We've assigned them to have students assign them to complete it, and they're like, oh yeah, it's busy work, we don't want to do it. By doing it class time and then having a faculty there to debrief and talk about it, as much, they pay to come here, they want to hear from us, right? As much as we say, like, this is a really expensive product and you should be really happy to be using it, they still want to hear something from the faculty. So rather than just assigning it, taking some ownership as faculty and trying to demonstrate to them just how valuable it is, and then having that debriefing where you have people who are experts in certain areas talk about salient points with the entire class. Let the students talk about what they messed up. Again, they learned from each other. The other reason that's important for faculty for debriefing, and I think we can all attest to this, is sometimes students don't know what they don't know. And that's also another helpful thing to have faculty there to help them understand what they don't know, and help them understand the whys behind why we do certain things. So we think for us, for a very long time we kind of looked at these and our students just didn't, again, talked about it as busy work. We don't love it. It didn't come up good on our evaluations. But I think the biggest piece of it is really having that faculty ownership and that faculty interaction with the students. And that debriefing piece of it is really helps the students grow.
So this case was actually used in my course during the summer. And what was really nice is that I involved, Christine, right? So it's like we got to work as a team and showing the students how excited we are about it. And I'm like, do you realize how lucky you are? Like, this is a pediatric case and you have someone with 22 years of NICU experience.
She gave the number.
Right? So like an expert in the field. And it really, we had a great time. So this is one of my favorite slides. I could probably stand here and talk about the data that's embedded within this output for an hour, but I won't take up too much time. But you could see some of the information that we get as a program. So we could do this for individual student performance. So how is the student doing individually? How did that group perform on this case? Is there something that we need to do as the educator? Are we weak? Is there a common theme? Are we weak in maybe ENT? Are they not performing well in, for example, a pharmacotherapeutic involved in this case? So we could kind of tweeze out those sort of issues. Identify gaps in knowledge that are common throughout that cohort. So there's a lot of information on this slide. It's a good resource even for remediation, right? For the student themselves, can they go back and see, are they weak in an organ system? Do they need to revisit their cardiology information? So the students were asked, do you think that simulation was helpful in correlative medicine? And although Christine and I would love, for this number to be 100%, for our group of students, this 79% is really, really good. This is a great number. We were happy to see this. And also the opinions changed, as Christine mentioned. It's not a home activity where they're feeling like they're just, pushed to work through these, clicking through all the buttons. There was a lot of knowledge that we shared, as a team and within their groups. So some of the qualitative results, some of the feedback we got, they enjoyed how realistic it was. It's amazing that they enjoyed being under pressure. They loved being timed. And it's like, wow, like that's interesting, right? Like they want it to feel like they're in practice. And it made them think critically in managing the patients. So, going back to some of the quantitative, the numbers, in the past that these scored really low. So our program benchmark is a 4 on a Likert scale, 4 out of, it's on a scale of 5. Our students rated these in the past like in the low 3s. And for us, that's a red flag. Currently, the number is trending up. It's over a 4. So let's see. These are the past qualitative comments. Not an effective way to learn, did not convey the information effectively, boring, dull, not realistic. So they did not have fun with these in the past. We wanted to take out the data we wanted to tweeze out more information, like, are these worth it? Are they getting enough from it? So we even went back and pulled some of our preceptor evaluations. These are the clinicians on rotations, doctors, nurse practitioners, PAs, right? And how are they rating our students? Is there a change in what they're perceiving? So again, look at this beautiful info that we got, and specifically to highlight, what's trending up over the past few years: ability to work as part of a team, reliability, self-confidence, professionalism, and student preparedness. And remember, some of these changes, this was happening during, the technology when we're on cell phones, and maybe the social skills are, right? So some of that had a piece, even COVID, right? So these numbers are going up. So I feel like, it would be safe to say that it is helping, and we're going to monitor. Another thing that we're piloting these numbers and watching them. We performed a t-test just to compare, clinical notes and clinical documentation. So those students, the cohort that had that gaming piece, right, their notes were ranging like 95% versus the group that did not have this piece, where their notes were around 86%. Now remember, the gaming students they're writing their notes on the spot. They're being timed during this case, so there's a little more pressure on them. So this is really, it's nice to see. And again, just trying to think about other departments within the university and how can we help you, what can we share with you? There's so many things out there in terms of puzzles that you could use to solve a case or manipulate objects, adventures, right? Solving a plot, simulation we went over, where using real life machinery, right, to work through skills, and what's called edutainment. So entertaining with an educational goal. All these sort of video game activities that, depending on what the objectives of your course are.
We utilize multiple platforms within our program, and I think most of us as educators, we're just doing our best to keep up with the students and their growth and keep them engaged. There's nothing worse than feeling like we're losing our students or we're losing a class or that we're not meeting our outcomes. And as much as, we would like to I don't love change. I'll be completely honest. I don't always like change, but I think that there is some really great technology out there, and I think we have to think about it in terms of how we can use it as faculty to work with our students, not just give it to our students, like, okay, here, you do this, or this is available, or go online, not so much assignments, but how can we integrate it into our class time? How can we make our class time more engaging? How can we get our students more engaged? How can we demonstrate these progressions? How can we work on some of the soft skills? I mean, there's so many different areas that you can think about with virtual and role play simulation, and again, not just in medicine, and so many different areas of education that I think it's really important for us to think about investigating all of these things and thinking how we can integrate them into our curriculum. And what we have found in our program is that utilizing this technology and utilizing simulation has definitely had a positive outcome on our students and their future patients, hopefully.
Mm-hmm. That
That's it.
concludes the presentation.
That was excellent. Great.
Thank
you.
you.
Both summing up. You get to stay up there.
Oh, okay.
So we'll certainly take some questions, and I think Allison has the microphone working. So if you have a question,
ask
just
the questions in the mic because the video is recording and it'll only record it if you ask in the mic.
there you go.
The students that are sitting there saying, complaining that it's not real life, it's not this, it's not that, do they do a rotation in real life and then do this? Okay, because
So this piece, we tried to bring this prior to rotation.
I could see it as a before, have them do the rotation and come back, because patients aren't always very forthcoming.
You think?
Yeah, full disclosure, I'm an EMT, in addition to being a marketing professor.
Okay.
So my volunteer thing on the outside is I deal with patients. And they're on a bus and they say, oh yeah, and by the way, I have cancer. It would have been nice to know when we were back at your house or something. So I would think this would have great benefit of doing beforehand actual rotations and then come out of it afterwards, and they would probably appreciate the simulations much more so after experiencing real life.
So we do both. We get to do it pre and post rotations. So that enables us to track, are they meeting our program competencies? You know, are they up to speed? So there are some students that we could identify at risk in the didactic phase, so like prior to rotations, and then coming out to like after, you know, at the end of rotations, using our simulation and our, you know, faculty created rubrics, we can make sure they're ticking off our benchmarks. Absolutely. So the rubrics change as we move through the curriculum. So like early didactic versus post-clinical rubrics, they're hard, right? We expect a lot, and we should, right? You potentially have someone's life in your hands, you do. So, yep, we do it both. It's a good question.
One back, Allison.
Ibrahim Karai from Population Health. Thank you for this presentation. Now, speaking of change, I'm wondering, do you see this applied in your program kind of like widely, or is it only going to be restricted to the courses that you teach? I mean, the use of gaming and simulation. How widely adopted is that in the PA program? That is one. And the second question is, are you thinking or envisaging kind of applying this as an evaluation tool, kind of officially embedding this, you know, as part of a final examination evaluation, for example?
So the first question, we use it in multiple courses within the PA program. All of us teach in multiple courses within the PA program. So some of it is used in the classroom with faculty, with debriefing. Some of it is used when students are on clinical rotations for them to, and that piece of it, when they do that, when they're on clinical rotations, there's no faculty debriefing piece of it. But so we do use it in multiple courses within the program, but the one specific course that we have faculty involvement, it's only one course. It's not all throughout. And that has to truthfully do more with timing and scheduling than anything else. And in terms of thinking about using it for an assessment piece, I think as we're thinking about milestones and portfolios, this is something that could certainly be used if we're going to be going in that direction. At this point, we're still we look at grades. We don't really utilize portfolios or milestone. On our own, we track milestones, but it's not official. But I think the output that comes from this program can easily be applied to demonstrating the progression of milestones.
Thank you very much.
I'm just curious how much time it took you to customize that software, and if you know the expense to the school for that software.
Well, you know, we can't speak, I don't, you know, in terms of the expense, but definitely, you know, also to piggyback off of the last question, we wanted to make sure that it was worthwhile. You know, up front, there is time that faculty had to put in, you know, to mold these cases. And before we move forward, integrating it within other courses with the debriefing piece, we wanted to make sure it worked. So, yeah, I think that eventually we can make this like a well-oiled machine, but it's that upfront time that we really have to put into it.
But this particular company is very helpful. The rep that we use with this particular company is very helpful, even in terms of when we were initially getting metrics. So we have our classes kind of go by cohort, so our metrics were initially like all mixed up, and so that's not really very helpful for me to see how a student who just started, you know, a month ago is doing compared to, you know, and another student that is finishing up in 2 months. I don't want to see their metrics mixed up. I would want to see how one cohort is doing, so they were able to change the reporting. So they've been very helpful to us. So a lot of the curriculum piece was more kind of more for us that we had to do, and some of the software pieces of it and more of the technical stuff, we were like, this is what we need, and then they were able to do a lot of that for us.
Yep, please, go ahead.
I'm not sure if PAs have to go through a recertification. I apologize.
We
but
do.
Have you asked people who are going through a recertification? I know they offer like recertification classes out there for different things, but have you asked people who've been in the field how they feel about that, and then communicate that back to students today? Because I'm afraid students today may not appreciate it as much as someone who's been in the field and comes back and says, hey, this is useful.
That's interesting.
We actually had an adjunct help with they
Yes.
were on the case with us. So these were experts in the field that were practicing, and I have a thank you note from one of them, Shivana, that they appreciated it, and they shared that feedback with students. So yeah, like having that debriefing is where all of this comes out too. Like we get to talk, you know, as a team, and definitely the preceptors have shared that. They love the software. It's good.
Great. Well, I want to thank both Professors Pontrelli and Zammit again for a great presentation, and congratulations.
Thank you.
And,
Thank you.
Thank you all for the great questions.
Thank you.